So good evening, everybody, and welcome to this edition of Bone School. For further proceedings, I'll hand it over to Dr. Thomas Kishan for moderation. Over to you, sir.
Thank you, Ashok. At the onset, I'd like to welcome all of you to Bone School. So, for the interest of people who have not been to Bone School before, Bone School is an orthopedic teaching program that has been going on since the last 10 years. So we started in 2012. It's a monthly orthopedic teaching program, and each month is dedicated to a separate subspecialty of orthopedics. We also run skill sessions, which includes basic surgical skills like suturing, tendon suturing, skin suturing, and also an orthopedic skills course that includes work on sawbones. So I'd like to thank all the faculty who have consented to speak at today's session. Dr. Srimant, Dr. Suman Bairagowda, Dr. Manish, and Dr. Shah. Thank you very much for taking your time off. I know, evenings are family time. So thank you very much for taking your time off to spend at Bone School. I also like to thank Dr. Ashok Sham and OrthoTV, without whom we would not have been able to conduct this program online. And as you are aware, the reach of OrthoTV is enormous. So we get people joining the program from across the world. Thank you very much, Dr. Ashok, and thank you very much, OrthoTV. So just a little point for the participants, since most of you are watching this program on YouTube and you do not have a direct link to ask questions to the faculty, you can WhatsApp your questions to me at 9980400858, and then I will put the questions forward to the faculty. So I'll repeat that again. So if you have any questions to ask the faculty, please WhatsApp it to me at 9980400858, and then I can put these questions across to the faculty. So once again, thank you very much for attending Bone School, and I hope you find the session useful. We'll start off straight away, and I will hand over the control of the program to Dr. Srimant, who will be moderating the session.
Yeah.
Thank you, Srimant.
Yeah. Thank you, Dr. Thomas, and thank you, Dr. Ashok. So just to put things across. Yeah, I think my screen is visible now.
It has just started sharing. It's not come up yet.
Yeah, I think now.
Yeah. Yes, it's up.
Yeah. So I welcome all to the Ortho-Onco session.
It's gone, Srimant.
It's gone? Okay, let me just... I think there's some issue. Is it now reflecting? I think
yes, it's back. It's back.
Okay. Thank you, everyone. And
put it on. Sorry, put it on screen, on full screen.
Yeah, I think now it's clear, I guess.
Yes.
Yeah. Move this window away from the shared application. Okay. So I think now it's visible, the whole screen?
Yes, it is.
Yeah. So at the outset, I'd like to thank everyone for being across for this Ortho-Onco session. So just to introduce the faculty, I am Srimant. I am a consultant orthopedic oncosurgeon at Manipal Hospitals, Bangalore. And I'm happy to introduce Dr. Suman Bairagowda, who's another consultant orthopedic oncosurgeon at Mazumdar Cancer Center, Narayana Hill City, Bangalore. And also Dr. Jaimin Shah, who's a consultant in Ahmedabad at OsteoCare, and Dr. Manish Pruthi, who's a consultant at Rajiv Gandhi Cancer Institute, Delhi. So the topic is going to be, the flowchart is going to be like this. I'll be starting with basic evaluation of neoplasms of the bone. So we're going to deal with only bone neoplasms. And Dr. Suman will take over and try to, share his thoughts on what is biopsy and what are the minimal invasive procedures we do across. This will be followed by Dr. Jaimin Shah's talk of giant cell tumor of the bone, which is again one of the most common tumors which you do see in practice and also in the exams, and what is actually extended curettage and what are the other treatment options. And finally, another more serious topic is about limb salvage, which everybody is asked and does encounter in their teaching and their practice also, is about principles and reconstruction techniques. Just to repeat what Dr. Thomas said, kindly WhatsApp the questions to the below given number, And we'll be more than happy to answer any other questions after each and everybody's talk. And each talk would be somewhere up around 20 minutes is what we look at. Okay. So just to start with the first talk, I'll be sharing a few snippets about evaluation of bone neoplasms, and greetings from Manipal hospitals. So why do we need to actually see about, go through this whole meeting about bone neoplasms? Why? Because majority of them are large volume tumors. As you can see in this image here, each tumor has a varied presentation, and they do present in all shapes and sizes. So it's imperative that one is aware of at least the basics of what needs to be done when they encounter such situations in their exams or private practice. So how do we go about it? It's actually a simple approach. As you all know, nothing is left without history and physical examination. This is always followed by imaging. Imaging forms a very crucial component in bone neoplasm evaluation. And then this definitely helps us to do a small outlay of differential diagnosis. Once we get this right, we need to confirm the diagnosis. How do we do that? We need the biopsy. That again will be handled by Dr. Suman. And then we go on to staging, and the tumor board comes in, make sure the treatment gets the best of the option along with everyone in line with the latest guidelines. And finally, the treatment, which Dr. Jaimeen and Dr. Manish will be sharing across in both benign and malignant scenarios. So what are the clues in history? The most common symptom which we see is pain. And what sort of pain is it? Pain which is often worse at night or at during rest. A simple indication is worsening pain at night, and especially if a child has a pain which is relieved on analgesics, you can think of a diagnosis of possible osteoidostoma. But if there is an associated swelling which is rapidly progressing in size, you need to think of some aggressive neoplasm. It could be benign, it could be malignant. But the more the night pain, the more it is could be malignant or neoplastic. Next comes tenderness, swelling, lump. What we need to know is that any lump which is larger than the size of a lemon or more than 5 centimeters, I think it definitely needs to be evaluated. And problems in the movement of the adjacent joints are also again another history of complaint which you can see. The less common signs and symptoms are weakness, fatigue, sweats, and other constitutional symptoms. And we rarely do see fracture of the involved bone. That's a pathological fracture. More so in benign and less in malignance, and also more in bone metastatic lesions. And please do not forget, if you have any patient coming in with a history of cancer rising nowadays and anyone more than 30 years of age, always try to ask for a previous history of treatment of cancer. So, are there any specific clues for bone metastasis? Can we find out by the history itself, are we dealing with a primary or a secondary neoplasm? Yes, there are a few things: fatigue, dehydration, constitutional symptoms, pathological fracture, pain due to weakness in the bone, more of a generalized weakness, and often they'll have anemia also. If more than 30 years and you really have a suspicion, it's always better to find out constitutional symptoms like goiter, cough, lump, hematuria, and frequent micturition, just to see, to rule out the primary if it is you're looking in the direction. And often we say metastases are identified on regular surveillance of the primary cancer also. So one needs to be very, have a broader horizon when you're looking at the history, because history is just not pain and swelling. What about physical examination? Again, never shy away from the most important basic things: size, site, shape, temperature, margin, skin status, dilate veins, and scars especially. Yeah, they said biopsy scars. That again forms a very big crux of the treatment and the way we handle bone neoplasms. These are again the most basic items you see, and distal neovascular status and adjacent joint movements. As you can see here, there's a pretty large diffuse lesion arising from likely the distal radius and the distal forearm soft tissue of the bone, whichever component it is. It seems to have a more of a variegated appearance, threatening near fungation also. So one needs to evaluate all this, because your treatment depends on how you examine this patient and how you also assess the viability of the distal segment, that is a hand in this case, or a leg, or any other part in that case. So we come to imaging next. Again, we don't forget the basics. So there's basics everywhere. One is X-ray. We always try to see two views and involve both joint ends. The other is the ultrasound. Ultrasound is not used very commonly, but if it's a soft tissue lesion, we do tend to take some help of it. The most crucial aspect comes next, which is the MRI. Again, always try to take contrast in both bone tumors and soft tissue tumors, and try to use the full length of the limb. And CT scan, the role of CT scan is a bit limited, but if you're suspecting osteoidostoma or sometimes some sort of, you need to have to look at the bone quality or the matrix, maybe we can use it. But the limitation is there. MRI is more commonly used along with an X-ray rather than a CT scan. So what are the questions to ask? So in this talk, because I'm talking about the evaluation, I'm going to be having more emphasis, or I'm going to be placing more emphasis on imaging itself. So I'll be taking a bit of time in that, and I'll be running through the whole process there. So what do we need to see is the location of the lesion, the extent, what is the lesion doing to the bone, and what is the bone doing to the lesion. And finally, the hint as to the tissue type of the matrix. So when we see the locations, you can see here, epiphyseal, metaphyseal, diaphyseal, there are so many lesions which come across. The more aggressive lesions can be both in the, epimeta diaphyseal lesions, and there are, we need to differentiate between cortical and endosteal lesions also. As we say, most common epiphyseal lesion is a giant cell tumor. Again, in the young age, it's a chondroblastoma. So and so, osteosarcomas, Ewing's, where all they come across. This slide gives a very good depiction of where you can have the lesions, and it always gives you a hint when you see the patient. And next, we do come across what is the actual type of the destructive pattern which we see in this lesion. So again, Lodby classification, tries to tell us whether it's a geographic or a moth-eaten or a permeative type. In a type 1A or 1B or a 1C, as you can see here, the aggressiveness increases. So the sclerosis becomes less and less evident as time goes by. What does this indicate? A slowly progressive lesion can be walled off. That means it is more benign. Whereas a rapidly progressive lesion or an aggressive lesion destroys bone. Therefore, the sclerosis is less defined. So again, similar examples. Where do we see a type 1A sclerotic margin? Simple bone cyst, enchondromas, fibrous dysplasias, chondroblastomas, giant cell tumors. Very rarely chondrosarcomas or MFH or UPH is what we say. But as you can see here, the first 4 diagnoses are actually really benign lesions. When you see a well-defined but a non-sclerotic rim, we do see, okay, this could be likely benign, but it could be a bit more aggressive. So again, giant cell tumor is one of these presentations where often this rim may or may not be sclerotic. We do see such issues even in myeloma and metastasis also. And chondrosarcoma, again, we can definitely see some sort of a non-sclerotic margin, which may be well-defined. So what is the last type of geographic lytic lesion? That's again type 1C, which is more commonly seen again in giant cell tumors, chondrosarcomas, and you even see these in infections and eosinophilic granulomas and Ewing sarcomas. Second would be moth-eaten appearance, more common in malignant lesions or metastatic lesions. And again, permeative destruction, again more common in Ewing sarcoma, osteosarcoma, infections, and even some situations of Langerhans cell histiocytosis also. Next, we would like to see the reaction of the bone to the tumor. So if there's limited response of the bone, we try to see the lysis, the sclerosis, and if there is remodeling, we try to see the periosteal reaction. Again, a rate of growth determines bone response. Always a slow growing lesion, likely benign, has more sclerosis. That is, the body is trying to contain the lesion. Whereas a rapidly progressive lesion, which has more destruction, often tends to break through all the cortices, there will be less sclerosis, again indicating a malignant or a metastatic lesion. So these are the different types of periosteal reactions which we can see. We can see some continuous periosteal reactions. We can see interrupted. We can see complex. What one needs to note is that, again, continuous is more likely to be less aggressive, whereas interrupted is again more likely to be malignant or metastatic, whereas complex can be seen in both malignant and metastatic situations. A simple example is laminated or onion skin peel appearance, which we can see right here. Codman's triangle, again, a typical question which one would be asked during their exams or in their Viva OC, a lift off of the periosteal reaction when the tumor is trying to advance rapidly. So that small periosteal area is a bit ossified compared to the fastly advancing tumor pattern, which we can see. And this is very commonly seen in osteosarcomas. And tumor matrix, yes, solid, clawed, completely sclerotic, stipple, flocculent. So there are many types. What do how can we find out what sort of tissue we're dealing with? Definitely, yes. When you see stipple, flocculents, and rings and arcs, you are dealing with a chondroid neoplasm. Whereas if you see a fluffy, solid, or cloud-like, oh, maybe you're dealing with an osteoid neoplasm. That's what we try to look at. But most commonly, what do you see? Radiolucency, lysis. Again, a small depiction or differentiation between benign and malignant lesion. When you have a benign lesion, you have well-defined borders, lack of soft tissue mass, solid periosteal reactions, and geographic bone disruption. But on the other spectrum, you have an intrepid periosteal reaction, moth-eaten destruction, soft tissue mass, and a wide zone of transition. So this again picture, would help you to try to differentiate what sort of a bone neoplasm you're dealing with. So after an X-ray, we do come across an MRI. So this is a very typical presentation of an MRI. Again, another typical presentation of an MRI. What do we really see in these MRIs? We try to see the matrix, we try to see the extent on the T1, and also any skip lesions on the T1 and sturdimus, as you can see here in the MR of the femur, relation of the neurovascular bundle to the tumor. And MRIs also help us to plan the biopsy. So MR with a contrast is very essential when you evaluate a bone neoplasm, because it can offer a plethora of information as to what sort of a tumor you're dealing with, what is the extent of the tumor, and where should you plan the biopsy. Often we also do a dynamic contrast enhancement during the contrast phase, which also allows us to assess the activity of the lesion. CT scan, yes, the role is limited. We do often try to use it in cortical lesions and try to see the matrix of the lesion. Osteoidostoma is one specific place where we get less than 1 millimeter cut. And this is a typical presentation of an osteoidoma, as you can see the right upper hand corner. And also we try to do a non-contrast CT scan to isolate any metastasis in the workup of a primary bone neoplasm. Laboratory parameters, yes. No bone neoplasm evaluation is complete without laboratory parameters. What is the more important common parameters we need to see? Definitely complete blood count, total counts, alkaline phosphatase. Again, alkaline phosphatase helps us differentiate giant cell tumors and parathyroidism depending on the level which we see. Again, we need to see the serum PTH levels also. Lactate dehydrogenase and alkaline phosphatase are also markers for the aggressiveness of the lesion, or we call it as prognostic markers for osteosarcomas and Ewing sarcomas also. In metastasis, we try to do the basic serum calcium, phosphorus, and alkaline phosphatase, and also serum protein electrophoresis for multiple myeloma evaluation. And for tumor markers, we try to do all the available tumor markers with us, so as to try to find out what sort of a tumor are we dealing with, whether it's a primary or a secondary. And yes, this is another very important slide, but I think Dr. Suman is going to be handling about it. This obviously is the next step, but the reason I put this slide is we need to make sure we don't do the wrong biopsy, and that is going to be held up by our next speaker as to how we do the right one and get the diagnosis right. And another question, FNAC or biopsy? Biopsy is definitely the gold standard, whereas FNAC is used only in cases of metastasis or recurrence in specialized centers or surgeons with experience. Once we do all these tests, we get the diagnosis. What do we do with the diagnosis? We have a benign lesion or malignant lesion or a metastatic lesion. In case of a metastatic lesion or a malignant lesion, we try to stage the disease. We try to see the disease burden. So the most common staging protocol followed for malignant neoplasms are CT thorax followed by technician bone scan. And there is an option of whole body FDG PET-CT also. In metastasis and myeloma, we often use whole body FDG PET-CT. This is a typical example of how the whole body FDG PET-CT looks, and we get a specific SUV value, which also allows us to denote the activity of the lesion. And once all this is done, how does the patient get treated? Definitely by a tumor board, where all minds, surgeons, pathologists, and radiologists, and everybody else tries to sit across and try to give the best treatment possible. So I think just to summarize the whole flow chart, diagnosis is by clinical evaluation, radiological is by X-ray and MRI and CT if required. Histologically, we need to do a biopsy, which is a core needle biopsy held up by the next speaker. Staging is by CT thorax, bone, or PET scan, whereas management again would be whichever we look at as conservative and other modes of modalities, which our other speakers are going to be spoken about. So when you have this sort of a flow chart, you will know that you will not go miss any points during the evaluation of a bone neoplasm, and you will achieve the right diagnosis and the optimum treatment. So I think take-home messages, you need to always have a high index of clinical suspicion. Always go back one step when you don't get the diagnosis right. There is no shortcuts to diagnosis or treatment. When you follow this protocol, which is a very basic protocol, even which is known in orthopedics also, you will rarely tend to miss. So again, I would like to reiterate, if for residents who are going for exams, you don't have to reach the actual diagnosis when you are trying to go up and present a case. As long as you're going through the specific flowchart or the way the presentation has come across, you will at least land up in a differential diagnosis and make sure that it is definitely not a diagnosis way outside of what anybody would think it is. Multidisciplinarity, again, yes, that's the key to success. So when you are going to be asked questions about management, you should always start with this. And communication, that's one of the ways why and how we can try to treat these patients. Thank you. So I think the floor is open for questions with Dr. Thomas. Hello.
We haven't received any questions as of now, so we can probably go on to the next talk, and if questions come up, then I'll probably send it across to you, Srimant, and then you can ask the faculty. I think we can get on to the next talk, Suman's talk.
Yeah, so I'll just stop the sharing. Yeah. So Dr. Suman will be talking all about biopsy and minimal invasive procedures in the treatment of bone neoplasms.
Yeah, my slides are visible, Dr. Srimant?
Yeah, it's visible. I think you just need to go on full screen.
Yeah. So thank you so much, Dr. Srimant, Dr. Thomas, and Bone School for giving this opportunity. So today we'll talk about very important topic, that is biopsy, and also the minimal invasive procedure, what we are doing in the treatment of bone tumors. So the common scenario, what we see in our clinical practice is, most of the times the patient comes with a surgery done without a proper biopsy like this. The first case, there is a lytic lesion in the proximal femur. Someone thought it's an infection, went ahead and did debridement and plating. When the material was sent for diagnosis, it turned out to be osteosarcoma. So patient had to undergo hindquarter amputation. The second patient, same, there's a pathological fracture humerus, the nailing was done, and it turned out to be osteosarcoma because of the contamination which has happened during the nailing and the reaming. So patient landed up with four-quarter amputation. So another scenario, what we see is, so there is a case which is exactly like X-ray and MRI, as Dr. Srimant mentioned. It looks like a benign giant cell tumor. So based on the radiology, the surgeon went ahead and did an excellent curettage and plating and cementing. So when the specimen was sent for diagnosis, it turned out to be osteosarcoma. So patient had to lose his limb because of the contamination which had happened during the curettage. Sometimes they do biopsy, but the biopsies are incorrectly done. For example, in the case one, the proximal tibial lesion, so there's a biopsy across the knee joint. So there's contamination in the knee joint. So when we are doing a definitive procedure, we have to sacrifice the knee joint. In case two, the biopsy is done through the patellar tendon. So there is contamination of the patellar tendon. So we need to do some reconstruction option in this case. Case 3, there's a proximal femur lesion where the biopsy was taken like a posterior approach, and there is a contamination along the sciatic nerve. So patient had to undergo amputation. So these biopsies are very important. They're going to make a huge difference when we are treating bone tumor patients. The next question is when we should do biopsy. So the ideal is, as Dr. Srimant mentioned, we should take a proper history, clinical examination, get proper local imaging, that is the X-ray and MRI. Based on that, come to have a differential diagnosis, and then we have to do our biopsy. So I just skipped this slide. So we have to read X-ray. If we read X-ray under proper heading, we can diagnose bone tumors on X-ray in more than 90 to 95% of the patient. So based on this differential diagnosis and based on the MRI, so based on the extent of the disease and its relation to neurovascular structure, and also the solid component and the necrotic component, we plan our biopsy and we place our biopsy in that particular site so that it can be excised when we are doing a definitive surgical procedure. So, so this is a case why I have put this, why we have to do imaging before doing biopsy. So this is a case where the biopsy has been done outside, badly done open biopsy, and we can see there is so much contamination around the disease, so that it will change the character of the lesion first. Second, and it also allows to measure the disease extent more than what was there. And this contamination also adds up to the morbidity of the surgery. So always get a proper MRI and imaging, then do the biopsy. So which lesions require biopsy? Do we need to do biopsy in all the cases? The answer is no. There are few lesions which are found in asymptomatic patient, like an incidental lesions. For example, patient coming with knee pain in a 50-year-old, you get an X-ray, there is an enchondroma, patient doesn't need to do anything. Same with non-ossifying fibroma, small lesion, patient asymptomatic, nothing needs to be done. Aneurysmal bone is small, there is no chance of pathological fracture. If there's a good cortical support, we can just observe it without doing biopsy. And an osteochondroma, which is characteristic on X-ray, can be observed. So what I am saying is there are few touch me not lesions. If we see them on X-ray and MRI, and if they have those characteristic lesions, and where we are planning to observe them, not doing any major surgery, then we can avoid doing biopsy. So where we have to do biopsy? So any imaging which is showing aggressive benign lesions, or suspecting malignant bone tumor, or if you are suspecting a metastatic disease, or sometime infection, because infection and tumors are always, they mimic each other, and it's very difficult to differentiate on imagings. The next important question is why we need to do biopsy. The most important thing is, you can see on the right hand side, there are plenty of variety of bone tumors, and that each treatment of each tumor is completely different. Few may require adjuvant treatments, few may require chemotherapy, few may require radiation, and a few benign lesions can be treated without doing surgery. So we should have a proper diagnosis, so then we can treat the tumor accordingly. So doing a biopsy is very, very important for better patient outcome. So the mantra is, as orthopedic surgeon or any surgeon, we always tend to operate first. But what we need to keep in mind is, when we are planning for a surgery, better to put a needle first, get a biopsy, and then do a surgery. Nobody can sue us for doing a biopsy, but if we operate and if something goes wrong, then medical legally also will be in a big issue. So always put needle before putting knife. So this case why I am showing is which presented to me 3 years back. There's a lesion in the distal femur, and it was reported as giant cell tumor by a radiologist in Bangalore. When we did a biopsy, it turned out to be chondrosarcoma. So always never go with just report or image. We have to do biopsy, because sometimes even a benign looking tumor can turn out to be a malignant lesion. So always do biopsy before doing any major surgery. Next, who should do biopsy? Very important question. It should be done by the person who is dealing with orthopedic oncology cases regularly, who knows how to do the biopsy, and who is doing the definitive procedure, or even an intervention radiologist who is doing this kind of work regularly with the guidance of the surgeon, are the best person to do these biopsies. And better to do in a sarcoma center where you have all the facilities. For example, if you feel the material is inadequate, or if you are not hit the target properly, you can send the material for frozen if you are doing in some sarcoma center with good facility, and confirm whether you have taken the adequate material or not. So all these things matters a lot when we are treating a sarcoma patient. So this is a paper which was presented long back, which shows that the simple biopsies done outside can change outcome in 12% of the patients. So functional outcome, oncological outcome. So it makes a huge difference when we are treating sarcoma. Next important question, how we should do biopsy. So coming to biopsy, so there are needle biopsy and open biopsy. At present, there is no role of excision biopsy when it comes to bone tumor. A small incision biopsy we do when 2 to 3 times the needle biopsy fails. Otherwise, 90% of the time, or more than 95% of the time, we get adequate material when we do needle biopsy. And as Dr. Srimant mentioned, coming to needle biopsy, it's a true cut biopsy. there is no role of FNAC. Please, don't do FNAC for a bone tumor. There is no role. So we won't get adequate material or diagnosis with FNAC. So there are a lot of papers which has shown that the sensitivity is 90 to 95% and the specificity is 95 to 100% by using these simple needles when we do a biopsy. So FNAC, as I told, there is no role in diagnosing primary tumors. They can be used in recurrent setup. We know that osteosarcoma we have treated 2 years back, he comes with a swelling. If you can do a FNAC and just diagnose that, okay, there is a recurrence. But coming to primary setup, there is no role of FNAC as such. So advantage of needle biopsy, less tissue damage, minimal contamination, daycare procedure, cost-wise cheap, OT time is very less, no hematoma formation, less infection chance, and less chance of pathological fracture. So coming to open biopsy, advantages, you get more material. Maybe you need more material when you're doing some research, or if you feel that your pathologist is not that experienced in musculoskeletal oncology. So principles of doing a biopsy, any biopsy. So for example, lesion in the distal femur posterior aspect, the biopsy through the posterior direction is absolutely wrong. So ideal, it should be short rooted, in line with surgical incision, avoid neurovascular bundle, avoid intercompartment plane. So we have to go through muscle. Why? After doing the biopsy, when we do, the muscle contracts and it prevents the spread of hematoma. If you are doing in the intercompartment plane, which is the loose plane, there will be spread of hematoma and more contamination. Avoid going through joints, avoid transverse incision if you are doing an open biopsy, and we should know how to read an MRI to avoid necrotic material. So this is a common picture which is available in all the textbooks. When we are doing distal femur, if the lesion is more on medial side, we try to go through the vastus medialis. And if it's a lesion on more on the lateral side, we go for vastus lateralis. And same with the proximal femur, we are all try to enter through the vastus lateralis in the proximal femur lesion. Coming to proximal tibia, one thing we should keep in mind, never ever contaminate patellar tendon or joint. So if the lesion is more and looking aggressive, can be gone from a medial side. If the lesion is looking benign, if placed on the lateral, we can plan the lateral biopsy. Coming to proximal humerus lesion, always enter through the anterior 1/3 of deltoid, never through the deltopectoral plane. So just a small video of how we do a biopsy. So case of an aggressive looking bone tumor involving the distal femur. So we have got an X-ray, we got an MRI, and we know that it is looking like a primary malignant tumor. So the treatment will be wide local excision and it will be from the lateral side based on the MRI. So yes. And one more important thing I wanted to mention, always we need to take the biopsy from the periphery, and periphery doesn't mean that always it's in the vertical plane. The periphery can be in the transverse plane. So we don't have to always go to the end of the tumor. We can take it from the center of the lesion, and even this part acts as a periphery and where we get adequate material for diagnosis. So there's a small video of how we do the biopsy. So we always mark the incision. So this is my incision when I am doing a definitive surgery. So that's where from I'll be doing the biopsy. So we inject adequate local to the periosteum because there is a painful part. And once it's done, we use 11 blade to make a stab incision of 2 to 3 millimeters, very small incision. This is the gem-cherry needle which we use, which has a trocar inside. So the trocar is put into the needle and with rotatory movement, which is, and it's placed into the tumor. So always we need to put the trocar, otherwise initially we may get the soft tissue into the needle. So once we enter the tumor with gentle rotatory movement, we go and we take from different directions. So this is the movement we do. And once we done, the needle is taken out and the trocar is pushed inside, and you can see 1 centimeter of core which we get. So we can do repeat this procedure 3-4 times and get a 3-4 adequate cores from different direction and send for testing. So no suture required, just a compression band, no antibiotic, just painkiller. So it's a very, very simple procedure which can be done in daycare and it's not at all expensive. So when there's a cystic lesion, it's always challenged to do a biopsy because there is no hard material. So what we do is we put a needle, same gem-cherry needle, and with the help of needle, we try to scratch the walls because there is nothing will be in the tumor. So we need to take the lining epithelium for the diagnosis. So we scratch the wall and we aspirate the material. So you can see I'm aspirating the material. We do from all the walls and send it for the testing. Yeah, put it on a gauze and send the solid component for the testing. So a few things which we'll keep in mind: never ever divide specimens. Always send it to one pathologist. And if you want a second opinion, share the slides and blogs and get a second opinion, because we know that tumors are heterogeneous. Some pathologists may get a low-grade component and other pathologists get a high-grade component. So there will be a lot of confusion. Send it to one pathologist. If you want a second opinion, share the slides and blogs. And India, the infection is very common. So if you are suspecting infection on X-ray and MRI, please send for culture sensitivity. So we also use image guided biopsy if the lesions is quite deep, or if there is a lot of cystic component, we can use ultrasound, we can use a CT scan, or even you can use a PET scan to do a biopsy from high grade lesions. Coming to open biopsy, avoid exsanguination, contamination. We should keep it as less as possible. Make a deep incision. Never ever try to raise the flap. Go through the muscle and minimal retraction of the tissues, and avoid hematoma formation. So for that, you can put a bone wax or cement in the hole and make it a circular hole, because if it's a rectangular, there will be chance of stress rise and pathological fracture. And most of the times, no need to place the drain. If you are planning to place the drain, it should be in line with the biopsy incision what we have taken. So a well done biopsy needle, the amount of soft tissue we need to excise is very minimal. Even with the open biopsy, the amount of soft tissue we need to excise is very minimal. So, but most of the times in our practice, we see lesions like this, which significantly alters the outcome and also even make the surgery more morbid. So when we are doing a biopsy, we should always keep clinical picture, imaging, and histopathology, and all these three should go in hand. If your histopathology clinical examination is not matching with your imaging, or your histopathology is not matching with imaging, then there is something wrong. We have to go back and do the exercise from examination to clinical presentation and imaging, and discuss again in a multidisciplinary meeting to get a proper diagnosis. So a biopsy, take home message: get a local image. If you do a biopsy without having a differential diagnosis in mind, then you plan a surgery, we always land up in a big problem. So always do a local imaging, have a differential diagnosis. Based on that, you plan your main definitive surgery, then do a biopsy, and most of the times we end up with a good functional outcome. So biopsy is must. It's a simple day-case procedure, should be done by trained surgeon, no role of FNSC, don't divide the specimen. Send for culture sensitivity in saline if you're suspecting infection. Always discuss in multidisciplinary team. And most common thing is tumor doesn't spread by doing biopsy. So we have to do biopsy in all the cases. So coming to minimal invasive procedure, what we do in bone tumor at present days is the injection of sclerotherapy. That is, we use in primary aneurysmal bone cyst. Means the aneurysmal bone cyst which is not associated with a giant cell tumor or osteoblastoma or any other type. So it should be a clear primary aneurysmal bone cyst. So usually aneurysmal bone cysts were treated with extended curettage. The disadvantage is surgical morbidity. You need allograft or donor site morbidity for an autograft, or because we know that in children we can damage the epiphysis, and that's why the surgery is very morbid. So this paper came from our own All India Institute of Medical Sciences, where they started using sclerosant, that is polydoconal, for treatment of aneurysmal bone cyst. So the first thing we need to make clear is it's a primary aneurysmal bone cyst. For that, we should have an X-ray, we should have an MRI, and MRI will show characteristic fluid level. That means after standing for a long time, there will be blood cells which comes down and settles, and there is a serum in the upper part which looks white. So this is the characteristic finding which we seen in case of aneurysmal bone cyst. There should not be no solid component. If there's a solid component, then this procedure is not going to work. So exclusion, any secondary ABC, solid ABC, ABC if there is a pathological fracture, or ABC spine, because they are very close to neurovascular structures, and this sclerotherapy can damage these vital structures, so we avoid in this case. So what we use, 3% polidocanol. How much we inject? 1 cc per 1 centimeter cube. So maximum what we are injecting is 4 ml per session. So how does it act? It causes damage to the endothelial lining, triggers coagulation cascade, and causes occlusion of blood vessel by forming thrombosis. So what we need, simple J needle, local, and this is the minimal instruments what we need to do the procedure. So this is the procedure how we do. So we do most of the times under local. If it's a pediatric age group or patient is not cooperative, then only we go for a general anesthesia. We use usually CM to localize the lesion and inject a radio opaque dye to make sure the dye is not leaking outside. Then with the help of needle, we scratch the wall, break all the septae, aspirate the material, send for biopsy, and inject polidocanol into it. So this is a small video like how we do a sclerotherapy. So there is an aneurysmal bony cyst involving the rami of the pelvis. So we are injecting adequate local to that area. So then we using the Jemshiri needle. You can see my hand, and also in fluoroscopy with the needle, I am trying to break the septae in all the corners, so that when we inject polidocanol, so it goes to each and every corner and show its effect. So yeah, so then we aspirate the material, send for biopsy. So then we take polidocanol, maximum what we have injected is 4 ml till now, and inject with the saline into the different directions, so that the polidocanol reaches all the corners of the lesion. So once it's done, we take around 5 ml of saline and keep it in that place to prevent regurgitation of the polidocanol, because if it comes in contact with tissue, it can cause tissue damage. So complication can be associated with tissue necrosis, erythema, skin damage, fibrosis if it comes with normal tissue, and very rarely embolism and hypersensitivity can happen. So assessment, so we always take symptoms and how the patient has responded, and also imaging when we are deciding whether the patient requests further injection or not. So this is an example treated with 2 injections of sclerotherapy. So you can see the lesion has well healed. So this case is taken from my friend Dr. Rajat Gupta. So that's the outcome. So there's one more case of aneurysmal bony cyst treated with single injection of polidocanol, and you can see the function of the patient, and you can see a small scar of the sclerotherapy. So it's a minimally invasive, avoid all surgical morbidity, and gives excellent functional outcome. So there are a lot of articles which are shown that it has an excellent outcome. So at present, we have stopped operating aneurysmal bony cyst. The other method what we use, minimally invasive method we use in bone tumors, is the radio frequency ablation. So what is radio frequency ablation? So in this, with the help of guidance, we keep a needle in the lesion, and we're going to produce a temperature of 95 degrees. So that's going to kill the cells in it. So where it can be used? It can be used in case of chondroblastomas and osteoid osteomas. So this is a case of chondroblastoma of femoral head. If I had to operate this case, we have to cut the capsule, dislocate the joint, and then we need to operate. So that can lead to a lot of morbidity, avascular necrosis, collapse. So in this case, what we have done under CT guidance, we have put a needle and burnt the lesion by using radio frequency ablation. So you can see here, PET scan before doing procedure, uptake, there is an active lesion, and PET scan after doing procedure, there is no uptake. So it has taken care of the disease. So there are a lot of articles which have shown excellent result with RFA for chondroblastomas. So these lesions usually we use for smaller lesions of less than 2.5 centimeter, and we know the advantage, it avoids surgical morbidity associated. Another important indication for radiofrequency ablation is the osteoid osteoma. For example, this is the osteoid osteoma, and the small lytic area is the nidus. And the main culprit which produces the pain is this nidus. So when we are operating, we need to aim and remove this nidus, not the sclerotic part. But these nidus are usually 5 to 6 millimeters and very difficult to localize under C-arm or when we open during the surgery. So we end up removing a lot of bones. Sometimes we may miss it. And because we remove a lot of bone, patient can land up with pathological fracture. So what we do in this procedure is under CM guidance, you can see here, the needle is placed and we are going to produce 95 degrees with RFA and burn the lesion. So similarly, there is a lesion in the posterior element of the spine. Needle is introduced and the ablation of the lesion was done. So same thing. So there is a lesion in the femoral head which is treated. A larger lesion can be treated with a multiple prong RFA material, RFA probe, so that will even take care of a larger lesion. So thank you so much.
I think Dr. Suman has finished his presentation.
Yes, yes. Yeah.
Thank you so much, Dr. Suman, for taking us through the biopsy and the minimal invasive procedures. What I would like to ask you is, could you just clarify again, which sort of an aneurysmal bone cyst do you do sclerotherapy? And is there any other smaller procedure without any injection which you can do for aneurysmal bone cyst?
See, the first, as I told you, the main indication is a primary aneurysmal bone cyst. Means in MRI, we should make sure that there is no solid component. Or if there is any doubt, we have to do a biopsy and make sure that this aneurysmal bone cyst is not associated with any giant cell tumor or osteosarcoma or fibrous dysplasia or chondroblastoma. So then only we can do it. Even in case of solid aneurysmal bone cyst, this procedure is not going to work. So we have to make sure that it's a primary aneurysmal bone cyst, first of all. Second, there is procedure known as curopsy, where we don't put sclerosant injection, but we just put a biopsy needle and do a mini curettage, like we scratch the wall in all the directions. That can induce inflammatory process and healing of the lesion. So this process, this procedure is actually published by Royal Orthopaedic Hospital, where they have showed healing chance of around 80 to 85%. But with polidocanol, the healing rates is around more than 90 to 95%. But still, if you want to avoid polidocanol, you can just do curopsy.
And is this a single stage procedure, or does a child or a patient need multiple sittings sometimes?
Yeah, few patients need multiple setting. That assessment we do, we call the patient after 6 to 8 weeks, look at the symptoms, get an X-ray, see whether there is any healing. So based on that, we take a call. Usually, in most of the studies, and even in our practice, most of the lesions, the average number of injection required is hardly 2, not more than that. There are only few cases which have required 3 to 4 injections.
Thank you, Dr. Suman. So again, so when residents are, or do come across a situation where they have to present an aneurysmal bone cyst, either in the theory or the practicals, I think right now 2 established modalities is a minimal invasive procedure and a surgery, which is a curettage and bone grafting, which probably is the same like how we do in a giant cell tumor also. Thank you, Dr. Suman, again for your presentation. I'd just like to remind the viewers that if any questions are there, you can, just WhatsApp the questions to Dr. Thomas Kishan on 99804 00858. Just repeating it, 99804 00858 is a place where you can WhatsApp the questions, so that all the speakers will be more than happy to get forward and try to answer yours. Next, I would like to...
Dr. Simon, a couple of questions for Dr. Suman.
Oh, okay. That's great.
So what is the size of the Jamshedi needle?
11. Usually we use 11.
Use 11. And how much of material is required how much material do you aim for? How many cores do you aim for?
Usually,
is there anything like that?
Yeah, if you are taking from a representative area, a core of 3 to 4 cores from different directions will do. But main thing is we have to target that representative area based on the MRI. So if you're taking even 10 cores from the necrotic area, then your pathologist won't be able to give diagnosis. So we need to plan from where to do biopsy, and from proper area. Even if you get proper 2 to 3 core, that is more than sufficient to do all the IHCs and all even the translocation.
Dr. Thomas, just to add on this, what
Sure.
Suman has added, what Suman has spoken, like the 3 to 4 cores of around 7 to 8 millimeter in length. But yes, we should understand the lesion also, because when the lesion is cystic, as Suman has shown, we are not expecting the cores to come. We
Yes.
just get
Yes.
some membrane of the lining. Okay,
Sure.
so we should know the type of a lesion that we are dealing with,
Sure.
and then only we can expect. Because if you expect a core in a cystic lesion, I think you will keep wasting time and you will keep puncturing the bone only.
Correct.
Yeah, so that is what we should be
Thank you.
aware.
Yeah.
Can
One
I
last
ask one
question.
question to
Oh,
Suman? Can I
sorry.
ask?
Sorry. Carry on.
Yeah. So Suman, if you get a negative biopsy, so you have done a core needle biopsy. So how will you proceed that further? Like suppose a patient comes outside from with a needle biopsy and non-representative, or you do a biopsy and it is non-representative. So how do you proceed in that scenario?
If the patient, if it's done by coming from outside and done by a not a trained person, then I will 100% I go and do a needle biopsy again.
Okay.
If I have done a biopsy and if I am sure that I may not get an adequate material than what I have in the previous procedure, then I may go for a open biopsy. Or if I feel that by doing a second procedure or by using a image guidance, I can target the proper area, then I still go for a needle biopsy.
So you want to do at least 2 needle biopsies before going
Yes,
ahead.
usually before going to open biopsy, at least 2 attempts from a trained person is what I
Thank
follow.
you.
So I have one small thing to add here. So for residents who are asked such questions in both sectors when for the exams, I think it's better that we put it across that an image guidance is always better for doing a biopsy. I think the overall picture is better because they will know from where to get the tissue. So an image guided biopsy, whether it be a fluoroscope or a CT, would be the ideal way to do a biopsy to whatever Dr. Suman has added.
Yeah, it's always better to do under image guidance.
Yeah. So Dr. Thomas, any other questions?
Yeah, there was another one where they said, is it okay to do a biopsy before more advanced imaging like PET CT and things? So you do X-ray, MRI, biopsy, and then decide whether you need a PET, or do you have to go in that order of doing all your imaging first before you do a biopsy?
Yeah.
I mentioned one thing. So it's the local imaging. So we have to complete all the local imaging before doing a biopsy. That is X-ray and MRI. If usually we get a PET to know whether the cancer has spread to other part of the body. If we are getting PET CT to get more information about the primary lesion, then yes, do the PET CT and then do the biopsy.
Okay. Oh, thanks, Suman. Thank you. That's all the questions we have. Srimant, you can.
Thank you, Dr. Suman. Yeah, so now I'll request Dr. Jaimin Shah to share his presentation on giant cell tumors, how he does extended curettage or how it needs to be done the right way, and also the other treatment options in giant cell tumors. Dr. Jaimin, please share.
Yes, just a minute. Am I audible?
Sorry, you are audible.
Yes.
But your presentation hasn't come up as yet.
I have shared a screen, so it's visible. Is it visible
Not
now?
yet.
Not yet. Oh. Why is it so then?
Maybe you can just go onto the slide presentation screen, and I think that should be able to share it.
Is it visible now?
Yes, it is visible.
Okay. So can I start?
Yes, please.
So thank you, Srimant and Dr. Thomas for giving me this opportunity. So basically, I will be talking about. I was asked to tell about what is an ideal curettage in a GCT and some more information about some newer drugs in GCT. So what do you mean by curettage? So whenever the word curettage strikes in our mind, we take it very easily and just we think that it's simple safsafai. What is a major issue in that doing a curettage? But it is not so. Curettage encompasses a lot of things, and as you can see, these are the points which have to be included in doing a good extended curettage in giant cell tumors. So I'll just point it out point by point, and just we'll see how important are these points. So exposure is the key to do an extended curettage. If you do a mini hole exposure in a curettage, you are very liable to fail. So always don't hesitate in putting big incisions. A wide exposure will help you in getting to the disease properly. So traditionally we were taught that you should make a window into the bone, but now that era is gone, and now what we do is make a big door. So if you want to enter into the house, obviously you will enter through door and not through a window. So keep a big door, not a small window. So the main important thing is then you have to protect the surrounding structures. So what we follow is, after making a good incision, we just protect the boundary of the disease with an hydrogen soaked gauze species, so that even if there is some spillage, it is contained into that thing and not into the nearby structures. Because these are most common thing that is there. So as I said, we have to make a large cortical window after going up to the disease. After making a cortical window, you have to use these main instruments, which are scoops, curettes, and rongers, to do a simple curettage. So after doing this curettage, this is the thing that we are left with. But this is not thing. If you think that just by doing this curettage everything is over, the answer is no, because still the thief is still there. So what to do now? See, these are the gross ridges where the microscopic disease will be left. So you have to remove these ridges to get rid of that microscopic disease. There are a lot of accessories which we use in extended curettage, and main are these pulse lavage and hydrogen peroxide. Hydrogen peroxide is thought to be a tumoricidal. So we usually use a lot of hydrogen peroxide while doing curetages in giant cell tumor. So this is how, after doing curettage, we do alternate pulse lavage and hydrogen wash to get rid of that disease. So is it still all over? The answer is still no, because we still haven't used our Brahmastra, and that is burr. Without using a high speed burr, any curettage done in GCT is not an acceptable thing. So we always have to use a high speed burr to do an extended curettage in a GCT. So what we use is a 50 to 60,000 RPM of burr to reach each nooks and corners of the cavity to have an extended curettage. So regarding adjuvants, there are a lot of adjuvants which are being propagated: cement, phenol, alcohol, argon, and everything. But what we follow is just a proper extended curettage done with a burr is more than sufficient to have a less chance of recurrence. Still, the role of adjuvants is not proven till date. So this is just a slide to show what are the advantage of extended curettage. So on the left side, when we do a simple curettage, it is just the boundary of the wall that we are curating, and after doing an extended curettage, we are removing 1 or 2 millimeter more of the disease, more of the wall of the disease. So we are getting with a less chance of recurrence, and this is the advantage of doing an extended curettage. So I'll just show a video of an extended curettage. So this is a giant cell tumor of a distal end of femur, and as you can see, we are removing this extraosseous disease which is there. And as you can see, the gauze species which are there helps in protecting the spillage which might be there. So after removing this extraosseous disease, or what you call a door to the disease, you will be left with an open disease. So then we have to do a simple curettage with the instruments that we have discussed, such as scoops, curette, or maybe a good spoon like this. So we can easily remove the disease. So next, after removing this gross amount of disease, we can use a curette, as I will be using it now, to just remove the disease. So this is known as a simple curettage. So this is the way that we do a simple curettage. So we have to remove, and this is the ridges which are left after doing a simple curettage. And this is a pulse lavage that we are using it just in case to remove the disease. And this is the burr that we use it to remove the ridges of the cavity. So this is the advantage of using a burr. So the microscopic foci of disease which is there, which helps in removing that microscopic foci. So what will be the end point of doing this burring? So we usually take a paprika sign, what is known as a fresh oozing from the cancellous bone, and as you can see, there will be slight oozing from this cancellous bone, and we take this as an end point of the curettage with a burr. You can appreciate some capillary filling. So this is what we have recently applied. After doing this extended curettage, we use high-end cautery just to cauturize the walls of the cavity. It is just a extra thing that we do after doing an extended curettage, and then fill the cavity with whatever you want, cement or a bone graft, whatever you feel. So this is again a small video. Just to show that these are the soft tissue boundaries that we need to take out before doing a curettage, because these are the things that leads to recurrences. Hello? Am I audible again? Hello?
Yes, you are audible.
Okay, fine. So, take home message for these curetages: do a biopsy, do extended curettage, do try to use adjuvants, proper reconstruction, and do the counseling properly. So, the next part of the talk is what are the newer things or newer drugs which have been used in GCT. So basically, there are two drugs which we are using in GCT. One is the bisphosphonates, and mainly that is zoledronic acid, and the other is denosumab. So we'll see each of them in few slides. So basically, what is the mechanism of action of both the drugs? So what happens in GCT is there is a mononuclear stromal cell which secretes the rank ligand, which binds to the rank receptors on the osteoclastic precursor cells, and which activates the osteoclastic cells to start the lytic activity in the bone. So what denosumab does is it's a rank ligand inhibitor. So it binds to the rank ligand, and which stops the activation of the osteoclast, and the lytic activity is stopped. Whereas bisphosphonates, it's a nitrogen containing compounds which act directly on the osteoclastic cells and causes the phagocytosis of the osteoclastic cells. So basically, denosumab acts a step higher on the pathway, and bisphosphonates acts at a ladder down. Denosumab is a static thing, whereas a bisphosphonates is a inhibiting thing. So we have to keep in mind that thing. So how does it help in GCT? So how can we use it? So basically, bisphosphonates we can use preoperatively or postoperatively, whereas usually denosumab is used preoperatively, and as a definitive agent in very selective cases. How do we administer bisphosphonates? So we usually give zoledronic acid 4 milligram IV in 100 ml NS over 20 to 30 minutes slowly. We have to repeat every monthly, and the frequency depends on case to case basis. It should not be used in pediatric patients. You have to check serum calcium and phosphorus before administering, and after administration of bisphosphonates, there are scenarios of having patient complaining of nausea, fever, and vomiting. So you have to supplement paracetamol to 3 to 4 days. And obviously, a long-term effect is an osteonecrosis of the jaw. Also, you have to take care of renal impairment before administering a bisphosphonates. So same, what is the dose application of denosumab? So traditionally what trials have been done, the landmark trial which told that it can be given 120 milligrams sub-Q on 0, 7, 14 and 28 day, and then we have to repeat every monthly. Again, frequency depends on case to case, and we have to supplement calcium and vitamin D3. So regarding this regimen, there are now several modifications regarding dosing which are now evolved, and there are various centers which uses a short course pre of denosumab before a surgery, maybe one dose today, 14 days later, and there are a lot of permutation and combination which have been used in dosing of denosumab. So what are the scenarios where denosumab can be used? So basically there are three scenarios where denosumab can be used. First is to facilitate a resection to a curettage. So as we know, a giant cell tumor is a tumor which occurs in very young patients. So if we are going to do a resection, put in a prosthesis, we are definitely sure that it will be needing a revision. So we always try to preserve the natural bone. So where pre-op denosumab can be used to convert that resection to curettage, we can use a denosumab. Second is always to facilitate resection. For example, very large giant cell tumors of pelvis or maybe some other areas where you are very much likely to spill the disease whenever you are doing resection, we can use a preoperative denosumab. And third is to facilitate curettage. These are the cases where you feel that even after doing curettage, you will be damaging the articular surface or nearby structures. You can give it preoperatively just to facilitate your curettage. And obviously there are very selective cases, as I told you previously, that it can be used as a sole agent, for example in large GCTs of sacrum and spine, where if you are contemplating a curettage, you are definitely sure to damage the sacral nerve roots and the spinal cord. There you can give a denosumab as a sole agent along with other techniques such as angioembolization. So this is one such case. As you can see, this is a young lady having a lytic lesion in the distal femur. It was a biopsy proven giant cell tumor, and you can see there is no wall whatsoever in lateral, some part of anterior and some part of the posterior cortex of the femur. Obviously some might agree that they can do upfront curettage, but we were not pretty much sure that after doing curettage we'll be able to prevent a pathological fracture or we'll be able to save the joint. So this lady was given 4 to 5 doses of preoperative denosumab, as I have told in the last slide. And then after doing this denosumab, as you can see, what a good osseous rim which is formed around the tumor, and which is very well appreciated in the fresh CT scan. So now we are pretty much sure that we will be able to do a curettage and we will be not getting into a pathological fracture. But doing a curettage in a post denosumab giant cell tumor, it's very trickier, because as you can see now the disease is completely sclerosed. So while you are doing a curettage, you will not be knowing whether you are curating a normal bone or you are still into an abnormal bone. So in curating such cases, we usually take help of an intraoperative guidance just to check that we have curated to every nook on corner of the disease. And so we were, after doing curettage, we had filled that cavity with cement and plating done, and the patient was fine. This is another case, a large huge GCT of acetabulum, in which as you can see, there was, because of the lysis of the acetabular floor and the dome, the femoral had protruded into the cavity. So if you try to do a curettage or resection in such cases, you are very much liable that you will be doing a lot of spillover into the cavity. So we decided to give preoperative denosumab in this case, and as you can see, a nice osseous rim was formed around the disease, and which helped us in doing a good type 2 internal hemipelvectomy, and then pseudoarthrosis was formed. So basically, what I wanted to tell is zoledonic acid and denosumab are two one I can say wonder drugs or good drugs which are there in our armamentarium, but we have to use them very judiciously, and if used properly, they can give us good results. Thank you.
Thank you, Dr. Jaimin, for your presentation. I have a question for you.
Yes.
What do you do in pathological fractures of giant cell tumors?
So there are pathological fractures can be of two types, whether it's an intra-articular undisplaced fracture or an extra-articular displaced or undisplaced fracture. So if you have a intra-articular fracture, then I usually tend to go in straight away without giving any denosumab, and then try to reduce them and then do a proper curettage as I have described. But if there is multiple intra-articular fractures with old age, then obviously you will be not contemplating a curettage, and then you can do a straightforward go to a resection thing. If there is an extra-articular frankly displaced fracture, then it is dependent on case-to-case basis what to do.
Okay, so a pathological fracture in a giant cell tumor does not always mean resection. We can
Exactly. Exactly. So it depends on case-to-case basis what to do.
Yes, but options are still open for both types of.
Yes.
Okay, thank you.
Yes, yes.
Dr. Thomas, any questions from the audience?
Yeah, there was one, and it was regarding the spine. Okay. And the question was, giving denosumab in spinal GCT, would it reduce the neural compression or not?
What we have seen in sacral giant cell tumors is basically patients when present to us, they complain of having bowel and bladder disturbances. But as soon as we start denosumab, because of the sclerosis, the compression onto the nerve roots just stops, and they get relieved of these nerve root compressions. So it basically helps surely in sacral tumors.
Okay, so I guess it should help in the spinal tumors also. But how many doses? How quickly does this happen, Dr. Jaimin?
So, denosumab usually you will see good sclerosis within 3 to 4 doses.
Okay.
May I add another point here, Dr. Thomas?
Yes, sure.
Yeah. See, if there is an invasion into the canal space or there's a significant compression, what we see denosumab does is denosumab does not always try to shrink the lesion.
Yeah.
Losing compression quantitatively is not going to be very, what do you call, an advantageous thing.
Okay.
What you would get is an ossification of the rim by denosumab.
Okay.
So compression loss or recovery of symptoms is going to be much lesser for a short course compared to a long course. So if you're planning to do surgery, which is a mainstay of treatment there, it would be always be better to do an embolization and, with a short dose denosumab therapy, go up front with a surgery and which would relieve the symptoms. Okay.
Thank you, Dr. Sriman. Thank you, Dr. Jaimin.
Yes. Next, I just request Dr. I'll request Dr. Manish Puthi, who is a consultant at Rajiv Gandhi Institute, Delhi, to share his presentation on limb salvage principles and techniques, please. Dr. Manish?
Yeah, I'm there. Is it visible, Srimant?
Yes.
And am I audible?
Perfect.
Yeah, perfect. Yeah. So thank you very much, Srimant and Dr. Thomas, for inviting me here. So we'll be discussing in this presentation the principles of limb salvage and reconstruction techniques. So broadly, these are two different topics because we first need to understand the principles. and then only we can go ahead with the reconstruction techniques. But yes, any limb salvage surgery has two basic components, which are first is a resection and second is a reconstruction, and aim of this technique is to give a patient an optimal function. Okay, so as far as what I understand now is the patient has been underwent an appropriate biopsy as described by Suman, and patient has received appropriate neoadjuvant therapy before we contemplate a limb salvage. And the other most important thing that we should be aware of is that the patient has an appropriate chemotherapy gap. This I will be highlighting in the end of the presentation. So the aim of any limb salvage surgery is to achieve wide margins of the tumor and a function which is at least equivalent to or superior to an amputation. So that is when how we decide our limb salvage surgery. So this is the basically annexing concept of margins. As you can see, the red part is the tumor in the bone. So then we have four types of margin. First is an interlesional margin, which is done for benign tumors, which is going in the tumor and scooping it out. The other in the green is a marginal dissection in which we go through the pseudocapsule of the tumor. The third is the wide dissection in which we go through the normal tissue around the tumor. And fourth is the radical dissection, which is an extra compartmental dissection in which we have to remove the complete compartment involving the tumor. In a bone, it requires a complete removal of the bone. So let's start with an example. Like this is an osteosarcoma of a lower end of a femur in a young female. So these are our MRI, and you can see the extent of the disease in the longitudinal plane in the MRI. So as far as the longitudinal margins are concerned, for taking a wide margins, I think it is very easy to understand. This red block is what we need to take a longitudinal margin, which is around 3 centimeter or 2 centimeter margins longitudinally. Yeah. Sorry. Just a second. Yeah. So which is very easy to take. But what about circumferential margins? So if you can see the axial cuts of this patient, so we can see that the neurovascular bundle is lying very close to the tumor. This is the red circle, red oval is on the vessels, and the rhomboid is on the sciatic nerve. And this is the distance, the yellow square is the distance of the tumor from the skin. So all these are is less than 2 centimeters. So how we can say that we are doing a wide section of the tumor? So here comes the concept of natural barriers and the qualitative margins. So what is a natural barrier? It's anything which is present in the nature, which prevents some one thing to go to merge with the other. Like in this case, a rock which is stopping the sea to merge into the land. So in the same way, the natural barrier, there are some natural barrier for the tumor spread also. So this was beautifully described by the Kawaguchi paper in 1995, and they described the barrier as any tissue which has a resistance against the tumor invasion, which can include fascia, joint capsule, periosteum, vascular sheaths, and so on. And based on that, they divided the barriers into two things: the thick barrier and thin barriers. A thick barrier they called when we cannot see the underlying tissue through the barrier, and a thin barrier is when we can see the underlying tissue. The examples of thin barrier will be an iliotibial band, a joint capsule, or a periosteum of a young child or an infant. Examples of a thin barrier is a healthy fascia of muscle or the periosteum in adults, vascular sheath, and epinuria. So a thick barrier quantitates to a 3 centimeter margin, and thin barrier quantitates to a 2 centimeter margin. And if by chance in our imaging we see that the tumor is reaching one surface of a barrier, then we have to reduce by a centimeter. So going back to our case, what about the circumferential margins? We know that around the yellow square, we have a deep fascia of the thigh, which is a 3 centimeter margin. And around the neurovascular bundle, we have a vascular sheath and epineurium, which also quantitates to a 2 centimeter margin. So that is how we decide in a longitudinal plane and a circumferential planes that we are wide and we are resecting with the safe margins as far as the tumor excision goes. But the problem comes, there are certain challenges to the surgeon. So these are the common challenges that we face when we are contemplating a limb salvage. as Suman has highlighted, a poorly placed biopsy incision is a big problem. Then comes the involvement of major vessels, involvement of a major motor nerve, an infection, or inadequate motors after resection. And usually this happens when there is a very large tumor that we see. So we'll discuss these one by one so that you understand what we can do in these scenarios. Going to the first problem, a poorly placed biopsy incision. Like in this case, a clear cell sarcoma of the proximal tibia, you can see a open biopsy was done with a big hatch marks on the medial side. And in the MRI, you can see that the bone was also involved. So in this case, when we resect the skin on the medial side, we have to put some flap because the closure will not come. So if a needle biopsy has been done as Suman has described, then a flap could have been avoided. But now this patient required a bone resection, a reconstruction with a cement spacer, and a rotation flap to cover the skin defect. So poorly placed biopsy incisions give us a trouble in terms of like more number of reconstructive surgeries that these patients require. Another very common error that we face is we get a one negative biopsy, we do it from a different site. As Suman has told very clearly, we can repeat a biopsy but through the same incision or do an image guided, but do not repeat a biopsy through a different site, because in that case we have to resect a very long segment of the skin. Other issue that we face in a challenge to a limb salvage is the involvement of a major vessels. In this case, recurrent soft tissue sarcoma involving now the femoral neurovascular bundle. So what we did is we resected the soft tissue mass with the femoral vessels, and as you can see the gap in between with the bulldog clamps, and this was reconstructed with a femoral vessel graft. So we can resect the major vessel and reconstruct with the vascular graft, and that is acceptable. And sometimes we are able to succeed and do a successful limb salvage. Encasement of a major motor nerve is a major issue in the lower limb, but not much in an upper limb, because upper limb we have three major motor nerves. Like in this case of a synovial sarcoma of the forearm involving the ulna and involving the ulnar nerve. So what we could do is we resected this tumor with the resection of ulnar nerve and with the ulna intercalary resection, and then reconstructed with a vascularized fibula graft with the skin cover. So this is how the reconstruction looked like, with a plate and a vascularized fibula in between and a flap. And this is the function that the patient could get. Patient is having an ulnar claw hand, but having a good normal elbow functions, yeah, and good forearm rotations. So basically in upper limbs, even you are losing one nerve, you can still get a much better function than an amputation. But in lower limbs, if the sciatic nerve is involved or the tibial nerve is involved, I think patients are much better with an amputation than resecting the complete nerve. Preoperative infection is a major issue, and we will not be able to use the conventional prosthesis when the patient presents with an infection. So this was a case of a dermatofibrosarcoma. This is a soft tissue case, but involving the spinous process. Is having a very big tumor with an infection all around. So we could resect this, use multiple flaps to cover. We resected the spinous process and covered those with the flaps only. And this is how the healing could happen. So for soft tissue case, usually the flaps will suffice, but for a bony tumor, we can put a primary cement spacer laden with the antibiotics rather than putting a prosthesis. But yes, we can still do a salvage of the limb. Coming to the other major issue, which is inadequate motors after resection. This happens when there is a pathological fracture through the tumor in the joint, where the joint is contaminated, or there's a huge tumor which is involving all the muscles. So this was a patient with an osteosarcoma with a pathological fracture, which is intra-articular, contaminating the suprapatellar pouch. As you can see in the MRI, there's the fluid in the suprapatellar pouch. So in this case, what we can do is do a complete extra-articular resection, will not open the joint, and reconstruct with some sort of an arthrodesis, because now you cannot put a conventional prosthesis and get a function. So in this case, we did an arthrodesis using a vascularized fibula. Patient had a mild skin necrosis superficially, which was managed with debridement and skin grafting, and the patient ultimately had a good function, like having a stable arthrodesis and can lift the leg without SLR and without deficit. So basically, uh, this is the only major contraindication that you can expect when there is loss of motors in lower limbs. If you are losing a rectus femoris muscle, then a conventional megaprosthesis cannot be put. So either you have to resort to an arthrodesis, or you have to resort to a amputation. So going how we decide on these, like what is the best reconstruction that will be suitable for our patients. So we usually follow certain algorithms or certain principles so that the patient is benefited the most. So basically the reconstructions options are decided upon the type of resections, the available motor muscle groups, the socioeconomic status, local skin condition, as I have told, the need for adjoint treatment. This is what we should always keep in mind, and the availability of the supportive department, which might not be there in all the institutes, which are the tissue bank, the reconstructive surgery unit, and the radiation unit. So as far as the tumor surgeries are concerned, we basically do two types of resection. The first is an articular resection, in which the tumor is removed with a part of a joint, or an intercalary resection, in which the bone is removed, sparing the joint above and the joint below, so that we can salvage the joint, and just we have to recycle or replace that segment of the bone. So I will be going step by step on the various sites and the type of resection, so that everyone can understand how we are choosing the reconstruction option. In upper limbs, in articular resections, suppose the tumor is in scapula or in the proximal humerus or in the clavicle. So as far as the scapula and the proximal humerus, they actually behave in a similar way as far as the functional outcome after reconstruction is concerned, because patients only get a good elbow and hand function. We aim to give them a stable shoulder with minimal active movements, because when we are doing a shoulder dissections in a proximal humerus, a person is losing insertion or the origin of all these muscles or the axillary nerve, which will not give much of a shoulder function. So this is how the function will be. Patient gets an elbow and a hand function, but no shoulder function. Sometimes we are able to spare the axillary nerve in a proximal humerus resection, but we lose the rotator cuff, so we can put a reverse shoulder kind of a prosthesis. And with this, a patient can get a function for certain duration of time as far as the shoulder function is concerned, but ultimately these prostheses get loosened over the time, and they have to convert into only a stable shoulder. As far as the clavicle resection is concerned, patient usually gets a good shoulder, elbow, and hand function with a minimum restriction of movements, but sometimes they get a little weakness in throwing or a lifting kind of activities. This was done for an Ewing sarcoma of the clavicle. Elbow resection, the prosthetic replacement provides a near normal joint range of movement, but the only thing that the patient limits is a lifting of a heavy weight. We can replace the elbow joint and get almost from 0 to 90 or 100 degree of movement, but we cannot allow them to lift very heavy weights. As far as the distal radius resections are concerned, which is a very common site for a giant cell tumor, we usually perform a wrist arthrodesis, but we perform it in a little different manner. I think most of you are aware of this technique now. Our aim is to give them good elbow, forearm, and hand function, but no wrist movements. So this is what we do. We do an ulnar translocation. We resect the lower part of a radius and shift the ulna in place of a radius, and use a long plate from radius to the ulnar segment to the third metacarpal, so that the forearm rotations are there. So this is how the post-operative picture and the final healing will look like. And you can see the function here. Patient gets a good elbow, a good forearm supination, pronation, good grip, and uh, almost normal looking a functional wrist. But the wrist is fused, but the patient are able to do most of the activities. We can also do a total humerus resection, and when we are doing an articular, and this is also functionally similar to proximal humerus. But the elbow range of movement can be limited if we lose lot of muscles around the arm. So, and we can replace it with the total humerus prosthesis. As far as the lower limbs is concerned, articular resection of a proximal femur is reconstructed with a megaprosthesis, and the megaprosthesis, the capsule is reconstructed with a proline mesh, and the muscles are reattached to the prosthesis, which are the iliopsoas and the abductors. So this is a proximal femur chondrosarcoma reconstructed with a proximal femur megaprosthesis, and you can see a proline mesh sutured around the prosthesis neck for reconstructing the hip capsule. As far as the knee is concerned, this is the most common site of bone tumor, and the mobile joint with an endoprosthetic replacement is the reconstruction of choice. But arthrodesis is also compatible with a good function. For distal femur and proximal tibia, we are reconstructing with a standard megaprosthesis, which can be a fixed hinge or a rotating hinge design. And patient usually gets a good function when we put a megaprosthesis. They are able to ambulate from day one and get a good knee range of movements in the immediate post-operative period in distal femur. In proximal tibia, we wait for 6 weeks for the soft tissues to heal. But megaprostheses usually are durable and can give a good function. We can also do a knee arthrodesis because of various reasons, whether socioeconomic or because of the tumor resection or because of the joint contamination. We can do a biological arthrodesis during a turnoplasty or a vascularized fibula, or we can do a non-biological arthrodesis using a primary cement spacer. So, in fact, we published our data from Tata Memorial, in which I was one of the co-author of using a primary cement spacer in a knee tumors, in which we use a knee arthrodesis in 12 and an intercalary spacer in 3 cases, and this patient did very well in a short term as far as even the temporary arthrodesis with a primary cement spacer is concerned. We can also do a total femur resection nowadays when the tumor is contaminating either the full bone or patient has been nailed because of the tumor thinking of a metastasis. Like this patient, a 44-year-old male, presented with a pathological fracture in the femur, and someone plated him, and then he presented to us. We diagnosed it with a high-grade sarcoma of the bone, and the patient had some healing on chemotherapy. But now, because in MRI the disease contamination was right up to the knee and up to the upper part of the femur, so the only option was to resect it completely and replace it with a total femur prosthesis. So this was the final post-operative radiographs, which is replacing the full length of a bone from the hip to the knee with a total femur prosthesis. As far as the ankle is concerned, when we are doing an articular resection of the lower end of a tibia, we can centralize the fibula and do an ankle arthrodesis. So this is how we do. We just centralize the fibula into the place and use a plate for fixation from talus to the proximal tibia. And this is how the final picture will look like when the bone hypertrophies. You can see how beautifully the fibula has hypertrophied and took the place of a tibia, but the ankle is arthrodesed in some time. As far as the intercalary resection goes, in the lower limbs, we can preserve the joint function and we can use various reconstruction modalities. I will be highlighting these one by one. The most commonly used reconstruction in an intercalary resection is an extracorporeal radiation therapy, in which what we do is we first excise the tumor in the standard way of a wide margins. Then we take the tumor bone into a separate trolley and remove the tumor soft tissue, then wrap it in the plastic sheets and the mops, send it for the radiation facility, and then this tumor bone receives a very high dose of radiation, which is 50 gray in a single fraction. We get the same bone back, fix it with the plates and screws in a standard orthopedic way. And the advantage is we are getting a contoured graft. There is no need for a vascular surgeon or a tissue bank. And this is how the patient starts ambulating. Patient initially remains non-weight bearing for the time the bone to heal, but we can start the knee range of movements immediately. And once the bone heals, which is usually 6 to 9 months, the patient can start weight bearing, and you can see what function we can achieve. It's almost like a normal knee and ankle function, and patient is walking full weight bearing on this. If we have a good reconstructive surgery team with us, a plastic surgery team, we can do a vascularized bone transfer. So in this case of an earlier treated Ewing sarcoma with radiation therapy presented with infection, So patient had a very significant bone loss in between. You can see a very large gap between the proximal and the distal fragment. So what we did is we took an allograft from the tissue bank, got a vascularized fibula from his other leg. We put this reconstruct with a long plate, and you can see the final X-ray picture of allograft with a vascular fibula in between and fixation with a long plate. The patient had a wound infection post-operatively, but that was managed with the colistin lavage of the wound and antibiotics by an infection control team assistance. So this was the final picture, and this is how he looked like after 6 months. There was no infection and the wound healed beautifully. So if you have a good vascular surgery team, you can use a vascularized fibula to fill the intercalary defect. In lower limbs, you have to use an allograft with it. In upper limb, only a vascularized fibula will suffice. This was his radiographs at final follow-up. And ultimately, an happy patient at the time of a discharge. In intercalary section, we can also use a nail cement spacer. If we have a limitation of the resources, we can put a plate and reconstruct the area with a cement spacer, or we can use a diaphyseal prosthesis. A diaphyseal prostheses are usually costly because these are almost all porous coated or HA coated, and they are custom made. So usually a diaphyseal prosthesis will cost between 10 to 15 lakhs if you're getting an imported prosthesis, or around 4 to 5 lakhs if you're getting an Indian prosthesis. So very rarely we are using a prosthesis, but yes, these are also an option in intercalary resections. In tibia, in intercalary section, we have a good bone lying by the side, which is a fibula. We can just centralize the fibula to the tibial area and do a plating and give them some immobilization and wait for the fibula to hypertrophy. So last but not the least, I'll just cover pelvic resections. We know the type of pelvic resections. Type 1 is an iliac resection. Type 2 is a periacetabular resection. Type 3 is pubic resection, and type 4 are sacral resections. So for postgraduates or for residents to understand, for resections not involving the acetabulum, we are not reconstructing. So in this case, a chondrosarcoma involving the ileum, the yellow lines are marking our pelvic cuts. We have not done any reconstruction, and these patients do well. We just keep them in bed for 4 weeks and do a progressive weight bearing. This was the patient's post-operative function. At like almost at 6 months follow-up, patient is able to do almost all the activities, and that too without any limitation. But when the resections involve the acetabulum, we have to do some sort of reconstruction. We can use the same principle of extracorporeal radiation therapy, resect the tumor bone, recycle it and fix it with plates. We can do an arthrodesis as Dr. Jamin has shown. We can resect, do an arthrodesis of the remaining femur with the pelvis, or we can use a proline mesh for a pseudoarthrosis, in which we just resect, put the femoral head in that area and use a proline mesh to secondly stabilize it. So when you are doing a resection of the acetabulum, you have to do some sort of reconstruction to stabilize it. So even we published our data of limb salvage surgery in primary malignant pelvic tumor. This was a huge data of 106 patients, and we got a very good function and the survival in these patients. And you can see the overall survival was 67%, and patients in whom the acetabulum was retained had a better function compared to the patient in whom the acetabulum was resected. So to conclude, a good limb salvage surgery is just a part in comprehensive management of primary bone tumors. If you ask me, it is almost only 33%. The rest 33% will be an adequate chemotherapy, and the most important thing will be an adequate chemotherapy gap, which is at the time of a surgery and post-surgery, starting the chemo as early as possible. And we need to learn to become oncologists, then surgeons, because our overall outcome depends upon the proper chemotherapy gap, and then the surgery. Thank you very much for patient listening.
Thank you, Dr. Manish.
Yeah.
Yeah. Dr. Thomas, any questions for Dr. Manish?
There was something on the sacrum, Dr. Manish.
Yeah.
The question was, do all sacrectomies, do you need to do reconstructions for all sacrectomies, like a chordoma, or can you get away without a reconstruction, and how well do these people do?
So yeah. So first thing is like sacrectomy. There's a very beautiful article which is published, which actually decide upon the level of the sacrectomy, and that whether the patient will need a reconstruction or not. So grossly, if resident wants to know, if you are resecting the both SI joint, if your cut is lateral to the SI joint on both sides, then definitely you need to do a spinopelvic fixation. Yes, if the cut is medial to even one of the SI joint, then maybe you can avoid a reconstruction. Reconstruction is, I'm talking about a implant here. Okay,
Yes,
but
yes,
yes, but all sacrectomies require a flap cover. Okay, that is
yes,
also a reconstruction, but
yes.
flap cover is compulsory in all sacrectomies.
Secretary.
Yeah, but yeah, for a implant, if your cut is only lateral to both SI joint, then you need to do on both sides. If you can save one SI joint, and then you need not reconstruct, but you can go through that paper. It's a very beautiful paper which describes the level of sacrectomy and the need for implant fixation.
Thank you, Dr. Manish
Yeah.
Pruthi.
I have a question to Dr. Manish. When residents get a pathological fracture situation in their exams, should they go as a treatment option for amputation in case of a malignancy, or do you think that they can also provide the option of limb salvage in situations?
So per se, Shriman, the pathological fracture is not a contraindication to a limb salvage, although it increases the recurrence rate, especially the local recurrence rate.
Yes.
Yeah, but we need to carefully examine the patient in terms of the displacement and the contamination, the soft tissue contamination that the fracture has caused. But yes, you can immobilize the patient, but do not try to fix the fracture. Just immobilize the patient, give the chemotherapy, and then reassess your bone in terms of the healing of the fracture and in terms of the ossification of the tumor. Okay, if your previous contamination is like that, you can still get some motors for the prosthesis to be put. You can do a reconstruction with a normal prosthesis or some like an extra articular with an arthrodesis. But if you are not getting any motors, then maybe you need to do an amputation.
Yeah.
So it depends upon many factors, but yes, pathological fracture is not a contraindication for a limb salvage.
So you mean to say they're not wrong in saying salvage, but again, it all depends on how the tumor responds to treatment or has responded to treatment.
And the contamination that fracture has caused.
I think that's a very valid takeaway point over there. Any other questions, Dr. Thomas, to Dr.
No,
Manish?
we had only one.
Okay. To any other speakers also?
No, that's all we have actually.
Okay. Then I think probably you can just take over the closing remarks, please.
Sure.
Yeah,
so I think we've had a very good session, and I would like to thank the faculty for the excellent talks. Thank you very much. Firstly, thank you for taking your time off. Number two, thank you for sharing knowledge. I'm sure the participants would have benefited immensely from this. Thank you very much to each and every one of you at the faculty. A big thank you to Dr. Ashok Sham and his team from OrthoTV for broadcasting this session. So with OrthoTV, we are able to broadcast our sessions across the whole world. And as a result of which, we have more people attending our sessions. Thank you very much, Dr. Ashok. And the last thing that I'd like to say is that the next session of Bone School is on the 18th of December, and the topic is spine. And it is going to be held between 6 and 8 p.m. on the 18th of December. So we look forward to seeing you again. And once again, a big thanks to all the faculty. Thank you, gentlemen. And thank you, Ashok, as always. Thank you very much.
Thank you all. Yeah, thank you so much.
Thank you. Thank you. So we're going to log off.
Yeah.
Thank you very much, gentlemen.